Hi, I'm Richard. I'm a speech and language therapist and a lecturer based in the UK. In today's video, I'm going to provide a step-by-step guide how I critically appraised a case control study using the JBI checklist for case control studies. I will be critically appraising determinants of speech and language delay among children aged 12 months to 12 years at Yekatit 12 Hospital, Addis Ababa, Ethiopia, a case control study, which was written by Feven Moges et al. And published in the BMC Paediatrics. In this study, the authors tried to identify risk factors which contributed towards speech and language delay in children in Ethiopia. I hope this video will be useful to students learning how to critically appraise literature, practicing clinicians, and members of the public interested to know how healthcare professionals evaluate different kinds of evidence. Let's start with a brief definition of what critical appraisal is. Critical appraisal is a systematic evaluation of research to assess its usefulness and validity to a given context. A critical appraisal checklist is a tool used to help readers with this evaluation process. Each checklist contains a set of questions designed to prompt the reader to look for certain information in the research. The number and kind of questions in a checklist depend upon the kind of study you are reading. The case control checklist used today is published by JBI. This checklist asks 10 questions and asks the reader to rate each question yes, no, unclear, or not applicable. I will now go through each of these 10 questions in turn and attempt to answer them. The JBI appraisal checklist suggests the control group should be representative of the source population that produced the cases, otherwise this will lead to selection bias. This is usually done by individually matching the cases, but can also be done by frequency or group matching. In the methods section on page 2, the authors explain that it is an unmatched case control study. In the inclusion criteria on page 3, the authors explain that the cases had been diagnosed with speech and language delay by speech and language pathologists working at the hospital. The controls were recruited from the paediatric outpatient department at the same hospital and attending for unrelated conditions. The authors confirmed they did not have a clinical diagnosis of speech and language delay. So for question 1 in the checklist, I would say no, the groups were not comparable other than the presence of speech and language delay. The unmatched case control design means the children were recruited from the same hospital population, but no attempt was made to individually pair or match the cases to the controlled children. The authors explained that the hospital is the only government hospital in the country which provides speech and language therapy. The authors suggest that this allows children from diverse socio-cultural backgrounds to use the service and means the sample is more representative. I think this is a highly optimistic interpretation. I think it's more likely that it introduces selection bias into the cases where children living in or close to the city are far more likely to be able to use the speech and language therapy service compared to, say, children from the Somali region of the country several hundred miles away. The fact that controlled children were recruited from the hospital also introduces selection bias and confounding, as these children are unlikely to be representative of children in the wider population as well, and may actually be closer to the cases than the authors realise. For example, if a child has a long-standing medical condition, they may have frequently had periods of illness and had to attend hospital, so they have not developed normally, and their attendance at school may have been negatively impacted as a result. The checklist suggests sources from which cases and controls were recruited should be carefully looked at so they are matched appropriately. We learned from question 1 that the study used an unmatched design, so for question 2 on the checklist, I would say not applicable. No attempt was made to match the participants. The checklist suggests that a case should be defined clearly based on specified diagnosis, definition, or matching by key characteristics to avoid bias. In the inclusion and exclusion criteria on page 3, the authors explain that the cases are identified by having previously been diagnosed with speech and language delay by speech language pathologists at the hospital and were currently receiving speech and language therapy. The control group consisted of children without a diagnosis of speech language delay who were receiving follow-up treatment for unrelated conditions. The authors then explain how they consulted with the therapists and parents or caregivers of the cases and controls and checked their medical notes to identify any factors that would exclude them from the study, such as a diagnosis of autism or cerebral palsy, etc. So for question 3 on the checklist, I would say no, the same criteria was not used to identify cases and controls. The cases underwent assessment from a speech-language pathologist, whilst the control group did not undergo any assessment at all. It is assumed that they do not have speech and language delay simply because they have no documented diagnosis. It's not clear from the study if the parents or caregivers of control children were asked if they had any concerns about their children's speech and language development during the interview or as part of the questionnaire. The checklist suggests it is useful to know if objective criteria were used for the exposure, as this decreases the risk of bias. In the data collection tools and procedures section on pages 3 to 4, the authors explain how they developed a questionnaire. They asked a multidisciplinary team of clinicians to check its face validity, which led to revisions before it was used with the participants. The authors assessed the reliability of the questionnaire by calculating Cronbach's alpha, which looks at how closely a set of items are as a group. All the domains assessed had values of 0.7 or above, which is commonly interpreted as acceptable. The questionnaire was administered by 3 nurses with undergraduate degrees, supervised by a more senior nurse with a master's degree. They gathered data from parents or caregivers of the children in the case and control group. So for question 4 on the checklist, I would say yes, the exposure was measured in a standard, valid and reliable way. The checklist suggests that assessment of exposure should have been carried out according to the same procedure or protocol for both cases and controls. We learn from question 4 that 3 nurses used the same questionnaire whilst interviewing parents or caregivers of children in the case and control group. So for question 5 on the checklist, I would say yes, exposure was measured in the same way for both cases and controls. The checklist suggests that the confounding occurs where the estimated intervention exposure effect is biased by the presence of some difference between the case and control groups. This influences the direction of the study results. In the independent variables section on pages 2 to 3, the authors list a wide range of socio-demographic, biographical, feeding, family and environmental related characteristics they collected data on. For question 6 on the checklist, I would say no, not all confounding factors were identified. The authors did not have a predefined risk factor in mind, so the distinction between the independent variables collected and confounding factors is not as applicable here as in other case control studies. Where confounding does occur is with the method selected for the recruitment of cases and controls, which were mentioned in questions 1 and 3. There is likely to be selection bias involved in both cases and controls in terms of who can access the hospital before recruitment for the study takes place. The study highlighted that the hospital's speech and language therapy department served the entire country, but no data was collected about where the cases and controls live. This is important as there are striking regional differences in Ethiopia, especially between rural regions where 80% of the population live and urban areas where the hospital was located, which are relatively affluent in comparison and have much lower poverty rates than the national average. I've included a figure from the World Bank Group's Ethiopia Poverty Assessment 2020, which identified distinct areas of low and high income for the capital city where the hospital is located. So even if all the participants were recruited from the city, it would still have been useful to collect information about where they live rather than relying exclusively upon monthly income. The study also did not recognise that the unrelated conditions which brought the controlled children to the hospital are likely to act as a potential confounder as discussed above in question 1. The checklist suggests that confounding factors may be dealt with within the study design, such as matching or stratifying sampling of participants, or in data analysis by using some form of multivariate regression analysis. We learned from question 6 that confounding factors were not identified, so for question 7 on the checklist, I would say not applicable. The checklist suggests establishing the objectivity of the outcome measure. how the measurement was conducted, and whether the measurement tool was a validated instrument. In the inclusion criteria on page 3, the authors explain that the cases had previously been diagnosed with speech and language delay by speech-language pathologists working at the hospital. The controls were recruited from the paediatric outpatient department at the same hospital and attending for unrelated conditions. The authors confirmed that they did not have a clinical diagnosis of speech and language delay. So for question 8 on the checklist, I would say no, the outcomes were not measured in a valid and reliable way for several reasons. First, the study does not explain how the speech-language pathologist diagnosed speech and language delay. Second, the outcome measure speech and language delay is not a widely used clinical term used by speech and language therapists. The authors use it as an umbrella term to refer to a wide range of clinical diagnoses, each of which has its own distinct etiology, presentation and prognosis. The socio-demographic characteristics reported on page 4 merge these categories further when they report that 70% of cases had an expressive delay, 14% had a receptive delay, and 16% had both. At this point, it's not clear whether they view speech as an exclusively expressive skill, therefore included as part of the expressive delays, or not. Third, the assessment of speech and language varies considerably depending upon the age of the child and their current presentation, e.g. using observation, parental report, informal tasks, standardized assessments. Given the extremely wide age range of the participants, this exacerbates this further and means it is likely that the cases will not have been assessed in a standard way, in the way usually referred to in a case control study. Finally, the speech-language pathologist did not assess the controls to confirm that they did not have speech-language delay. It is assumed that they do not, simply because they are unknown to the speech and language therapy department. It's unclear whether there was even any scope for parents or caregivers of children in the control group to report if they had any concerns about their children's speech and language development on the questionnaire or during the interview with the nurses. The checklist suggests the exposure period should be sufficient to show an association between the exposure and the outcome, but the exposure period can be too short or too long to influence the outcome. In the first column on page 3, the authors explain they included children aged between 12 months and 12 years. They did this to ensure the sample size for the study was large enough, as there was budget and time constraints involved in recruiting a larger sample. So for question 9 on the checklist, I would say no, the exposure period of interest was not meaningful. The exposure period was selected for pragmatic, methodological reasons rather than being based upon theories of critical periods of speech and language development, which is problematic for several reasons. First, recruiting very young children does not give a sufficient exposure period for some variables to affect development. It is likely that you need to have long and sustained exposure periods to negatively impact complex behaviours such as speech and language. This means some risk factors are potentially excluded as non-significant due to the inclusion of very young children. Second, recruiting very young children makes it difficult to accurately distinguish between speech, language and communication disorders. The study excluded children with other medical conditions, but this is only effective if the conditions have already been identified and diagnosed. Difficulties with communication in young children are often non-specific and could be indicative of conditions such as autism, hearing impairment and learning disability. The fact cases have been diagnosed by speech and language therapists does not change this fact. Therefore, the potential inclusion of these children affects the validity of the case group. Third, many young children who are considered to have speech and language delay catch up without any intervention needed. Their inclusion in the case group potentially exaggerates the impact of exposure variables. Similarly, some children who do not have speech and language delay as toddlers go on to develop speech and language difficulties later on. Their exclusion biases the case group towards children with early onset difficulties, which are sometimes not persistent. Finally, whilst having much older children in the sample allows for an appropriate exposure period, by having such a long exposure period, you potentially introduce other sorts of problems such as changes in exposure over time, loss of specificity, confounding, and the parent's recall bias around exposure variables. The checklist suggests when deciding whether statistical analysis was appropriate or not, to consider whether there was a more appropriate alternative statistical method that could have been used instead. The methods section should be detailed enough for readers to identify which statistics were used and how specific confounders were measured. On page 4, the authors explain that they were going to use IBM SPSS to perform chi-squared tests followed by logistic regression. The study used chi-squared tests to identify which of the socio-demographic, biological, feeding, family-based and environmental factors had the largest associations with speech and language delay. These were all then reported in tables 1 to 5. After that, they included variables that had a p-value of 0.25 or less in the logistic regression. They explained that they used a higher p-value so as not to exclude any potentially useful variables from further analysis, and this is a relatively common approach in epidemiological studies. The logistic regression allows the authors to calculate the independent effect of each predictor variable whilst controlling for other factors. The results of the logistic regression are presented as adjusted odds ratios. These help isolate the effect of the risk factor after accounting for other variables in the model. An odds ratio greater than 1 suggests the risk factor increases the odds of the outcome, whilst less than 1 suggests it decreases the odds. In this case, scores higher than 1 suggest the child is more likely to go on to develop speech and language delay. Finally, they performed a multi-collinearity test and a Hosmer-Lemshow goodness of fit test to detect unreliable estimates of odds ratio and assess how well the logistic regression model fits the observed data respectively. So for question 10 on the checklist, I would say yes, appropriate statistical analysis was used. Having read the article and listened to me critically appraise it, how do you feel about it now? Did you agree with my ratings, or would you rate anything differently? I'm now going to share my personal thoughts about the piece and offer suggestions about how I think it could be improved. I think this study is well intentioned, but it does not add much to the current literature about risk factors that contribute towards speech and language delay due to its methodological flaws. In terms of how the study could be improved, I will give a few examples. First, the authors need to provide a much better justification for why they conducted the study and where it fits into the wider literature. As it stands, it's unclear what this paper adds to the literature on risk factors that contribute towards the development of speech and language delay. This point was raised during peer review, and the authors answered this by highlighting that no previous research had been done in Ethiopia, and the findings would provide valuable insights into the underlying factors that affect speech and language delay and aid in the development of effective interventions. It appears the authors felt this justification was enough and no further changes were made to answer this critique before publication. I agree with the peer reviewer and would go even further. The rationale that no previous research has been done in Ethiopia is only relevant if studies conducted in other countries cannot be used. For example, do the authors believe that there is something unique about Ethiopian children or their environment which affects their speech and language development? If so, they needed to explain what this was. If not, then they needed to review the literature and consider where their project fit into this. For example, were they trying to replicate the findings of other studies in a local context? If this had been done, it is likely that their conclusion would be that this study adds little to the literature in its current form. When reading the study's literature review, a particular red flag for me was the lack of any obvious references to large prospective longitudinal cohort studies, such as the Early Language Victoria study in Australia, the Ottawa Language Study in Canada, the Avon Longitudinal Study of Parents and Children or Millennium Cohort Study in the UK, and the National Institute of Child Health and Human Development Study of Early Childcare and Youth Development in the USA. It is unclear whether the authors were unaware of these studies, could not access them, or simply chose not to cite them because they did not think they were relevant to their context. I manually checked their reference list and looked at where the studies they did cite were conducted, and this was almost entirely similarly small studies published in the developing world, e.g. in Bangladesh, Brazil, Cameroon, China, India, Iraq and Nepal. There were minimal references to studies published in Australasia, Europe or North America. When the study did cite them, it was usually in the discussion section to contextualise their findings, rather than the literature review at the beginning of the article, which again is telling. The cohort studies mentioned above were often population level studies, including in some cases tens of thousands of participants, and have been running for 30 plus years. These studies use the best methodological design to identify associations between risk factors and the development of speech and language delays. In some cases, they've already answered the questions that the authors were researching, so replication was not necessary. This begs the question I raised before. Is there something unique about Ethiopian children or their environment which meant a new study was needed, which these much larger, more methodologically robust studies did not address? Is an underpowered case control really the best design to use to collect information on risk factors for what even the authors call a common childhood developmental delay? Second, and somewhat linked to the previous critique, the sample size needed to be significantly larger to meaningfully test for associations between risk factors and speech and language delay. Data collection lasted less than a month due to budget and time constraints. The decision to increase the size of the sample by widening the age range of the participants was not appropriate and introduced further methodological flaws into the design. It would have been interesting to know if the authors had originally had a much narrower, more developmentally appropriate age band in mind, or whether they started the research knowing full well that their recruitment phase was always going to be this short. An alternative approach could have been to consider using fewer interviewers over a longer period to manage the budget issue. Perhaps they could have considered using a role and recruitment approach which would not only reduce potential selection bias from the limited participant pool in April, but increase the number of cases and allow the authors to consider matching them to controls more rigorously. Again, I think this critique links back to the first point. What were the authors trying to achieve by doing this study? Finally, speech and language delay as a concept needed to be scrutinised more during the conceptualisation and design of the project. The authors presented it as an umbrella term when speech, language and communication are separate constructs which refer to a wide range of clinical diagnoses, each of which has its own distinct etiology, presentation and prognosis. The fact the concept of speech and language delay was not scrutinised meant subsequent issues were not recognised or rejected out of hand during peer review. This included things like not recognising why it was developmentally inappropriate to have such a wide age range of participants, not recognising that with this wide age range the children are exposed to fundamentally different communication environments, not reporting how the speech-language pathologist diagnosed speech and language delay, and not assessing the controls to rule out speech and language delay, etc. etc. If you found this video useful, give it a like and subscribe to receive notifications about similar videos in the future. You can also watch other examples of critical appraisal by clicking on the video on your screen now. If you've got any comments, questions, or have a request for other research you would like me to critically appraise in the future, then let me know in the comments below or get in touch with me on Twitter. Otherwise, thanks for watching and take care.